Okay, so sorry about that. I think we're back up and running. Allowed me a quick water break. Okay, so if you are interested in participating in any of these activities, I encourage you to register at the link on this slide. I'll also just add that all of the resources that I mentioned today are compiled in a summary slide at the end of the document. They're also currently available on all of your individual flash drives that you've received at check-in. And they'll also be available to you following the summit and shared to our IDPH webpage and our stewardship YouTube channel. So don't worry if you're not able to jot down these links just yet. So given their success and interest from facilities for continued targeted education and support, SIMPAR is currently recruiting on a first-come, first-served basis up to 15 facilities to participate in a 2-month, one-to-one mentorship program that will allow facilities to establish a stewardship program, work towards meeting regulatory requirements, meet directly with stewardship experts, and have the opportunity to receive sponsorship for stewardship certification. So if interested, again, on a first-come, first-served basis, I would encourage you to visit the sign-up form on this slide. So then in 2023, with leadership from the SIMPAR team, we also successfully launched the first pilot year of our PALAS collaborative, which stands for Partnering Acute and Long-Term Care to Advance Stewardship Efforts Collaborative. And this collaborative partners hospitals and nursing homes in a one-to-one partnership with a dedicated ID physician and pharmacist lead to help improve antimicrobial prescribing within each dyad's community. So the collaborative was launched with 4 hospitals and 12 nursing homes. And to date, all nursing homes within the collaborative have established a stewardship program. They've engaged their facility leadership. They've implemented an antibiotic timeout process, and they're currently working to establish a facility antibiogram. So again, if you're interested in participating, SIMPAR will actually be presenting some of their preliminary data from the collaborative during our poster session. So I'd encourage you to speak with them directly if any questions or if interested in participating. And we are currently recruiting hospitals to participate in this collaborative. So again, if interested, please visit the link on this slide. So then moving into the acute care setting, as mentioned, we are currently recruiting hospitals to participate in the PALAS collaborative, but I'd also like to provide a brief update regarding our IDPH antimicrobial stewardship honor roll program, as well as the current NHSN AUR module requirement. So for anyone who joined our U.S. Antibiotic Awareness Week webinar in November, you'll know that we had initially planned to launch our honor roll program earlier this year. However, given my leave at the end of this year, we actually decided to extend the launch to 2025. So we do apologize. However, for those of you who are just hearing about our program for the first time, I did want to at least provide a brief overview of our goals and requirements for participation. So our goals for establishing the Antimicrobial Stewardship Honor Roll program are first and foremost to recognize those facilities that excel and prioritize in implementing evidence-based practices of antimicrobial stewardship. We also hope to provide a platform for sharing best practices and fostering collaboration among participating facilities. And lastly, we hope to encourage facilities to continue to adopt robust stewardship programs to address the critical issue of antimicrobial resistance. So how did we develop our honor roll requirements? Well, given the national robust uptake of the hospital core elements with nearly 100% implementation nationwide, the CDC published the priorities for hospital core elements implementation in 2022. Now, these priorities highlight highly impactful implementation strategies that are supported by expert opinion and evidence, and key priorities have been identified for 6 of the 7 hospital core elements. Now, in 2022, while 98% of Illinois hospitals had implemented all 7 hospital core elements, only 7% had implemented all 6 priorities for hospital core implementation. So given this data, part 1 of our honor roll program incentivizes facilities to continue to expand their stewardship programs by implementing these 6 priorities for hospital core element implementation. And part 2 of our honor roll program encourages facilities to showcase antimicrobial stewardship collaboration. Now, our program is distinguished from other recognition programs in that we aim to go beyond the individual facility. So we're really aiming to recognize those facilities that engage in ongoing formal collaboration outside of their facility to advance antimicrobial stewardship. So the PALS Collaborative and the CHARM project, which I'll mention in the coming slides, are just two examples of ways to showcase antimicrobial stewardship collaboration. So prior to our launch, we'll be hosting a dedicated informational webinar with more information about the requirements and the application process, so more information to come on that. So given that the tracking priority requires or encourages facilities to submit antimicrobial use and resistance data to the National Healthcare Safety Network, I did also want to just briefly remind everyone of the current 2024 NHSN AUR module requirement. So beginning in January of 2024, AUR surveillance became a required measure to meet the public health and clinical data exchange objective of the CMS Promoting Interoperability Program. And this requirement requires hospitals and critical access hospitals participating in the CMS PI program to submit both antimicrobial use as well as antimicrobial resistance data to the NHSN AUR module. So I do hope that at this point, all hospitals in the room are familiar with this requirement. But again, if not, I do encourage you to bring this information back to your facility leadership to ensure that your hospital is working towards meeting this requirement. So then moving into the outpatient setting, IDPH has provided funding to Northwestern to support implementation of the outpatient core elements in 34 of their immediate care centers, 17 of which provide service to underserved communities. And as part of this funding, they've developed a series of one-page guidance documents for common outpatient infections as listed on this slide. And they're also currently working to implement an outpatient antimicrobial stewardship program implementation package targeted to outpatient facilities looking to establish an antimicrobial stewardship program. So topics within the implementation package include a background on the core elements, how to get started, identifying stewardship champions, tracking and reporting antibiotic use and clinical outcomes data, etc. So Drs. Denani and Sutton will be leading our outpatient track today, and they'll be providing an overview of their efforts in this setting. So if interested in speaking with them, I encourage you to visit that session. But in the interim, the guidance documents for common outpatient infections are currently available at the Northwestern ADSP webpage. So I do encourage you to visit the link on this slide for that. And lastly, in the outpatient setting, I am excited to announce our partnership with Ferris State University for the CHARM project here in Illinois. So CHARM stands for Collaboration to Harmonize Antimicrobial Registry Measures. So what does CHARM do? CHARM is a not-for-profit program based out of the Ferris State University College of Pharmacy, and their mission is to promote antimicrobial stewardship by providing clinicians with their prescribing practices in a user-friendly, standardized, and timely format. So CHARM partners with health systems to extract outpatient antibiotic usage data to create health system-specific, customizable interactive dashboards. So I'll review just a few screenshots from the CHARM dashboard here for your reference, but overall the dashboard provides utilization data down to the prescriber level and allows for flexible data analysis across the specific antimicrobial, diagnosis, clinic, prescriber, social determinants of health, etc. And it also allows you to evaluate antibiotic selection and dosing concordance with published as well as institutional guidelines. They've also most recently developed a HEDIS progress dashboard to monitor appropriate testing for pharyngitis, avoidance of antibiotic treatment for acute bronchitis, as well as appropriate treatment for upper respiratory tract infections. So we can toggle between a few different tabs on the CHARM dashboard. So on this dashboard, we can look at patient demographics, we can look at overall facilities, number of prescriptions, we can look at demographics such as sex, race, age, etc. If we toggle to the medication details tab, we can also look at specific medication details such as the antibiotic, dosing, duration, diagnosis, etc. And as I mentioned, you can look at selection and dosing concordance with your institutional guidelines. And as the name implies, this tab provides provider and facility level data as well. As mentioned, they've most recently added this HEDIS measures dashboard to monitor prescribing for pharyngitis, acute bronchitis, as well as upper respiratory tract infections. So in terms of who should participate in the CHARM here, we are currently looking to recruit hospitals and health systems across Illinois to participate in the CHARM project. Our goal is to enroll at least 8 health systems to develop a statewide dashboard to allow for anonymized benchmarking against peer institutions, as well as to help inform our IDPH efforts in the outpatient setting. So why should you participate in this project? Well, first and foremost, there is no cost to you. IDPH will be providing funding to our state to help develop your health system specific customizable dashboards. And you can use these dashboards to identify stewardship opportunities within your health systems, measure the impact of your interventions, and monitor progress towards meeting those HEDIS measures. You'll also receive access to aggregate data to benchmark against your peer institutions. And just from a regulatory perspective, CHARM fulfills 3 of JCAHO's elements of performance related to stewardship. So we do have Mike Klepser here from Paris State with us today. He'll be presenting during our poster session. So if any questions in establishing a stewardship program, getting access to your antibiotic outpatient usage data, or identifying stewardship opportunities by leveraging this health system specific dashboard, I would encourage you to reach out to him directly. You can also visit the link on this slide for more information regarding the project. So then next, I'd like to highlight some general resources and opportunities to get involved. So starting with US Antibiotic Awareness Week, this event is held annually each year from November 18th through the 24th to help raise awareness on the threat of antimicrobial resistance, as well as the importance of appropriate antibiotic use. So each year we distribute the Be Antibiotics Aware Toolkit. We distribute key messaging on our social media platforms and distribute various resources to healthcare professionals as well as the general public. This past year, IDPH partnered with Governor J.B. Pritzker to share an important message with all Illinois residents on the importance of appropriate antibiotic use. In addition, for the first time during US Antibiotic Awareness Week, we also hosted our Spotlight on Antimicrobial Stewardship, where we recognize the stewardship programs and efforts of healthcare facilities, local health departments, and organizations all across Illinois. So each of these sites submitted a video message to us that was then shared with stewardship champions and facility leadership across the state and are currently featured on our stewardship webpage. So we do encourage more facilities to share their video messages with us this November to be featured on our webpage. Another great resource is our IDPH stewardship webpage, as mentioned. So our site includes dedicated resources for each healthcare setting, acute care, long-term care, outpatient, dental, as well as the general public. And all of the activities, collaboratives, initiatives, and resources I mentioned today are listed here for your reference and are also available on the webpage. So then lastly, I'd like to highlight some of the great work from our local health departments. So starting with Lake County Health Department, they have been working diligently over the last year to work with local hospitals to develop a regional antibiogram to monitor ongoing trends in antimicrobial resistance and provide a resource to facilities that currently don't have access to a facility antibiogram. So they do plan to publish this antibiogram annually, and you can visit the link for more information. And then lastly, the Chicago Department of Public Health. They recently established a really wonderful NHSN AUR work group to provide technical assistance to facilities to help meet that current NHSN AUR reporting mandate that I mentioned. They're working to establish a Chicago Stewards to Antimicrobial Resistance quarterly call to create a space for facilities to exchange ideas and foster collaboration. And lastly, they are in the process of piloting a facility ICAR survey to evaluate facility antimicrobial stewardship policies and activities and aim to provide customized feedback. So in summary, I've provided contact information and QR codes for all of the activities that I've mentioned today. For any and all questions, I ask that you please do not hesitate to reach out to me, or even if you have an idea for a stewardship effort across the state that you feel IDPH can help facilitate, I ask that you please reach out to me directly. Or you can email our stewardship mailbox or visit the stewardship webpage linked on this slide. For all of our long-term care efforts, namely our regional workshops, our educational webinars, our one-to-one consults, and the Palace Collaborative, I ask that you reach out to the SIMPAR team at the email and web address linked on this slide. For access to the guidance documents and upcoming implementation package for the outpatient setting, you can reach out to the Northwestern team, Dr. Zanani and Sutton, at the email address linked here. If interested in partnering with us on the CHARM project, to establish a health system specific antibiotic usage dashboard. You can reach out to Mike Klepser or me directly and visit the Charm Project website. And for our local health department efforts, you can reach out to Star Cervantes, the CDPH lead at CDPH. I've also linked the CDPH HAN webpage as well as the antimicrobial stewardship webpage. And for our Lake County Health Department efforts, you can reach out to Dr. Sana Ahmed, and you can access the Lake County Regional Antibiogram here for your reference. So with that, thank you again, everyone, for being with us here today to celebrate our 10th anniversary of the Illinois Summit on Antimicrobial Stewardship. I do hope as you go throughout your day, you will remember Angela's message to make at least 3 connections, learn at least 2 new things, and share those 2 things with at least 1 colleague. So with that, I will pass it back to Raj. Thank you, everyone.
Thank you, Jamie. You got a lot on your plate, and you're doing it all so gracefully. And so thank you for just staying at it. I know some of these programs take a lot to get off the ground. Change is something that is not well taken by people, and including ourselves. So doing some of these projects that are so groundbreaking, especially Palace Collaborative, bringing the hospitals and nursing homes together. It took a while to get people going, but when they were going, gosh, they don't stop. So it's been, and I have a lot of people in the attendance here who are the proof of the wonderful things we can do. And when you go to the poster hall, you'll see several just amazing outcomes when people collaborate. And once just 2 completely spheres coming together. So again, thank you for helping all of us achieve that. And so next we have our CDC updates from Melinda Neuhauser. She's a known name here. She's been with us several times. We will have this session live streamed. And just quickly, a little background on our next speaker. Melinda Neuhauser is a pharmacist and acute care lead for CDC and Office of the Antibiotic Stewardship in the Division of Healthcare Quality and Promotion. Melinda graduated from University of Minnesota College of Pharmacy. She did her infectious disease residency training at Detroit Receiving Hospital and completed her fellowship training at the University of Illinois, Chicago, Illinois. Prior to joining CDC, Melinda worked as National Clinical Pharmacy Program Manager in infectious disease for the Department of VA Pharmacy Benefits Management Services, and was the co-chair of VA National Antimicrobial Stewardship Task Force. She also worked as a clinical pharmacist in infectious disease at the National Institute of Health, Clinical Research Center, and University of Houston College of Pharmacy, MD Anderson Cancer Center. Please welcome Melinda. I hope we have all technical things set up. And Melinda, you're up.
Great. Thank you for the kind introduction. And I really would like to thank the committee for inviting me to present again on CDC updates, and particularly a shout out to Shannon for accommodating my virtual presentation again. I really wish I could be in person and connect with old colleagues. As many of you know, I trained at UIC, and then when I was at the VA for a decade, and most of my life I've lived in Illinois, and definitely would be eager to meet new colleagues as well. But hopefully maybe next year I can be in person. Okay, next slide. We typically kind of really start a presentation highlighting that the ensuring appropriate antibiotic use or antibiotic stewardship, as highlighted by Angela, is one of CDC's 5 core strategies to combat the threat of antibiotic resistant infections. Next slide. And then the main guidance to improve antibiotic use across healthcare settings is through the framework of the core elements. And many of you are very familiar with the hospital core elements, which were originally released in 2014, and then we updated in 2019. And the core elements outline the structural and procedural components that are associated with a successful stewardship program. Next slide. And the core elements is a very adaptable framework, and the CDC released the core elements of antibiotic stewardship across U.S. healthcare settings, including nursing homes, outpatient, and small and critical access hospitals. And then this past fall, we released the core elements for public health to support our state and local health departments, such as Illinois and Chicago, that receive CDC funding. And these documents take into account the unique challenges and resources in the different settings that can guide efforts to improve antibiotic prescribing. And I'll have to say that both Illinois and Chicago are role models in implementing the core elements in health departments, and really appreciate our collaboration with Jamie and Star and the other teammates. Next slide. At the CDC, this is our team. Our stewardship team is comprised of multidisciplinary team members, including physicians and epidemiologists, a physician associate, and one pharmacist, who's me. We consider ourselves a small but mighty team. Next slide. The Office of Antibiotic Stewardship, we also use the framework of the core elements to organize our activities and really strategize for upcoming goals for the years. And so I wanted to use this framework to outline my presentation, to provide updates in the work that we do for tracking and reporting, action and implementation, and education and communication. Next slide. So first, I'll talk about tracking and reporting for antibiotic use. We know that measurement of antibiotic prescribing is critical to identify opportunities for improvement and to assess the impact of interventions. And this could be said at the hospital level or the individual healthcare level, as well as the state and the national level. CDC tracks antibiotic use nationally across the spectrum of healthcare through a variety of databases. For the hospital, we analyze the data electronically reported to the NHSN antimicrobial use option that Jamie discussed. We also leverage administrative data sources to characterize the appropriateness of prescribing practices. For the outpatient setting, we've been tracking national prescribing practices through a variety of data sources. Proprietary prescription data is stratified by state, is posted on our patient safety portal, and is a resource for our state health departments. We also leverage a variety of claims data to describe appropriateness of prescribing practices and tracking changes over time. Now, for nursing homes, we currently do not have a national data source to track antibiotic use. We've worked with vendors to characterize prescribing practices using electronic health records, as well as long-term care pharmacy data. It is exciting that NHSN is currently working on setting up electronic AU reporting from long-term care facilities. So we're adapting our successes and our experiences from the hospital setting to create a protocol for long-term care. We leverage the antibiotic resistant and patient safety portal as a data and surveillance tool for stewardship, and this really for the stewardship community. And this can be hospitals and healthcare systems and health departments. And this is how we share some of our national stewardship and antibiotic use data from different jurisdictions. For those that aren't familiar, the portal is an interactive web-based application that displays data collected through NHSN, the Antibiotic Resistant Laboratory Network, and other sources. And this is publicly available, and it really offers enhanced data visualizations for antibiotic resistance use and stewardship. This is a screenshot of the portal for hospital antibiotic use, and this is based on data from the NHSN antimicrobial use standardized antimicrobial administration ratio, or the SAR, which is our risk-adjusted summary measure. Hospitals can use this risk-adjusted summary measure of AU to compare antibiotic use to their state distribution to help identify meaningful SAR targets for improvement. As of July 1st, there's more than 3,800 hospitals that are reporting to NHSN. We often get questions on how you can utilize AU data for action, and wanted to highlight a new resource that we have. Is actually through funding that we provided the Duke Antimicrobial Stewardship Outreach Network, or DASON. This effort was spearheaded by Libby Dodds Ashley to develop resources leveraging NHSN AU data. This is once again an interactive web-based tool that is meant to show hospitals how to use their AU data to inform, implement, and assess stewardship activities. There are 15 clinical scenarios that were created from actual experiences from many different hospitals of using AU data for action. And there's 3 categories, as you can see here. The first category is based on using AU data to inform stewardship opportunities for high antimicrobial use. An example here would be an individual STAR category. The second category is using AU data to address opportunities to optimize AU. Example here is a classic scenario of IV to PO conversions. And then lastly, the category 3 is using AU data to support other quality initiative implementation, such as HEI outbreak investigation. And I want to highlight that each of these examples provide data that is specifically within NHSN AU data. And then some of them also provide as an additional step, if you have access to additional data, then you can incorporate more data. But the bottom baseline foundation is that each one of these case examples provide data of how you can really provide examples of how you can use NHSN AU data for action. Next slide. And this is the screenshot of the portal of using outpatient prescription data that CDC purchases from IQVIA. And this represents national prescribing volume and rate. There is a screenshot of, this is like a screenshot based on the state, and this is actually, I think, Kansas. I'm not actually fast enough to screenshot, and so I have to have colleagues to screenshot individual states. So next time I'll make sure I update to Illinois. But there are additional data showing distribution by patient demographic characteristics and antibiotic class. Just really wanted to highlight, we are expanding outpatient antibiotic use to the publicly reported CMS data, Part D, and that actually is going to be a soft launch this summer. And then during US Antibiotic Awareness Week, we'll be promoting that. In addition to IQVIA data, we do have CMS data as well posted on the portal. Next slide. So using the IQVIA data, we can track changes in prescribing over time. This graph shows national prescribing by rate by age group from 2011 to 2022. And you can see that prescribing rate has declined mostly due to the pediatric prescribing seen in green, where the older adult, except for changes observed during COVID, really has remained stable. We also assess prescribing based on different clinician groups using data, like outpatient data. And here you can see that there's no surprise that in 2022, advanced practice prescribers, so that would include nurse practitioners and physician associates, now account for 1/3 of all antibiotic prescribing in the outpatient setting. And this really underscores the need to integrate APPs into antibiotic stewardship efforts in the various healthcare settings. Another important clinician group is dentists. Although the overall rate of all prescribers has declined, like we just discussed, the dental rate of prescribing has not changed. Not shown on this graph, but general dentists now contribute to over 10% of the total volume of prescribing. It's important to note that these data do not include dental subspecialties or dental prescribing done by other clinicians. We also use claims data to assess appropriateness of antibiotic prescribing by indication. And through these analysis, we estimate that at least 28% of outpatient prescribing is not necessary. And then we also evaluate appropriate selection and duration that's not included in the 28% and found that there are opportunities to improve drug selection, dose, and duration. We've been working with pharmacy and long-term care partners to characterize antibiotic use nationally. This is an analysis of antibiotic use done in 1,700 nursing homes and found that 54% of residents receive an antibiotic at a rate of 88 days of therapy per 1,000 residents day. The advantage of using electronic health record is that we can classify antibiotic use based on the type of nursing home stay, either short stay or long stay. And then also when we did that, you can see here in the table that it showed that short stay residents had a 10-fold higher rate of antibiotic use compared to long stay residents. However, there's a large variability of antibiotic prescribing rates by facility, really highlighting potential opportunities for improvement. In addition to the electronic health record data for long-term care, we have been working with a large long-term care pharmacy database to evaluate AU through pharmacy dispenses. The dispenses are then aggregated into antibiotic courses and allow for the assessment of residents receiving an antibiotics and then calculating overall antibiotic use rates. We really like the focus on this course calculation because it allows reporting of duration of therapy, which we know is an important target for improving really improving prescribing, particularly in long-term care. The bar here represents the course duration, like the bar chart here represents the course duration, whereas the orange line is a cumulative percent of days of therapy. And you can see that most courses are 7 days, followed by 10. And we know that there's increasing data on shorter duration of therapy for common infections. And then what's unique to long-term care, courses that are longer than 30 days are not uncommon. Classically, as prophylaxis for UTI is often prescribed in this setting. Although these represent only 5% of the courses, they do represent 30% of days of therapy and could really provide another important target for improvement in this setting. Okay, next we'll go to tracking and reporting of stewardship data. And one of the ways we track antibiotic stewardship implementation is by assessing the uptake of all 7 core elements. These data are self-reported to CDC yearly through the NHSN annual surveys. We typically release the update of these data in November for US Antibiotic Awareness Week. And Jamie already presented the Illinois data, but here you can see the number and percent of hospitals meeting all 7 core elements reported to NHSN annual hospital survey from 2014 to 2022. In 2022, nearly 90% of over 5,000 US hospitals had antibiotic stewardship programs that met all 7 core elements. And this was even higher in Illinois. And then since we had such a robust uptake of hospitals meeting all 7 core elements, CDC released the priorities for hospital core element implementation that can help enhance the quality and impact of existing stewardship programs. The priorities are derived from hospital core elements and highlight a subset of effective stewardship implementation approaches that are supported by evidence or recommended by stewardship experts. And this really provides an opportunity for hospital leadership and stewardship programs to expand their stewardship program. And this is a screenshot of what we have on our website comparing the hospital core elements compared to priorities. And I think it's fantastic that Jamie and Illinois Health Department are focusing on the uptake of the priorities as a state initiative. And so we once again have the priority core element uptake showcased on our patient safety portal. And here you can see overall 10% of hospitals meet all 6 priority elements in 2022, with the highest uptake being pharmacy expertise and action, and then the lowest being tracking and reporting. And then it's important to note that although only 10% of hospitals met all 6 priorities, nearly half of the hospitals met 4 or 5 of the priority elements in 2022. And we feel that by highlighting these effective approaches for stewardship, we anticipate the priority uptake will increase in the upcoming 3 to 5 years. On the portal, we also report the uptake of the core elements in long-term care facilities. Core element uptake in long-term care facilities has also increased since 2016, as you can see in the dark blue bar. However, it is important to note, as you can see by the individual years, that there are changes in the number of long-term care facilities reporting. This is due to the support provided by CMS for NHSN enrollment, and the increased reporting in the past few years was due to the requirement of reporting for COVID-19 data. Next, I'll review activities under action and implementation. The core elements of antibiotic stewardship program play an important role in regulatory and accreditation of stewardship standards. They form the foundation of antibiotic stewardship standards for the Joint Commission and DNV. They're referenced in CMS's 2016 requirements for participation of long-term care facilities, as well as the 2019 hospital conditions for participation. As Jamie talked about, antibiotic use and resistance reporting to NHSN is required for all hospitals, including critical access hospitals that are participating in the 2024 CMS Promoting Interoperability Program, unless the specific exclusions apply. And definitely also wanted to highlight the move towards diagnostic and AU quality measures that can play an important role in optimizing antibiotic use. For hospitals, there is a National Quality Forum endorsed measure of inappropriate diagnosis of UTI and CAP for hospitalized patients. However, this measurement is based on manual data collection. CDC is working with partners on submitting an electronic measure for appropriate selection and duration for uncomplicated CAP to Battelle, which is the group that now replaced National Quality Forum. For the outpatient setting, antibiotic-related HEDIS measures are used by U.S. health plans and allow for comparison of quality metrics across providers. The HEDIS measures focus on diagnosis and treatment of respiratory infections that were created using a process of evidence review, testing, and stakeholder feedback. And it's too small to see the table at the bottom, but there is a link within the slide. We funded the IDSA through a cooperative agreement to create a clinical pathway for the diagnosis and treatment of community-acquired pneumonia based on clinical practice guidelines, which was posted this past fall. We often, particularly in small hospitals, receive feedback that the guidelines are fantastic, but it's a lot of work to operationalize the guidelines into a pathway. And so we use this opportunity to work with IDSA and had a committee of experts to operationalize the guidelines into this clinical path. It's important to note that when this is posted, it's really meant to be adaptable. So it's in a Word document, and you can then work with your P&T committee and stewardship committee to then potentially enhance your current pathway, or if you don't have one, then to use this as a template to really adapt to your individual formulary and testing practices. Along with the clinical path that's posted on IDSA website, there is a 20-minute webinar that provides the clinical overview of the pathway and the tables. And then we also have funded an IDSA panel to provide an overview of diagnostic and antibiotic stewardship principles that will be highlighted in the manuscript that is currently in development and hopefully be released in the near future. We also are funding IDSA to create a clinical path for complicated UTI that will hopefully be released along with the updated IDSA guidelines for complicated UTI, which are in the near future. We know that antibiotic stewardship guidance must evolve to address changes in the healthcare delivery. Urgent care and telehealth are settings where antibiotics are commonly prescribed, and guidance and resources are available and being developed to target these audiences. Our team published a paper reviewing the literature of AU, next slide, and stewardship interventions and highlighting how outpatient core elements can be adapted to improve antibiotic use in outpatient telemedicine. And this is linked at the bottom of the slide. And also, we are building partnerships with dental organizations to create new content on appropriate antibiotic use in dental settings and disseminating these resources and clinical practice guidelines. We talked about how adaptable the core elements are, and it is adaptable beyond stewardship. Last year, the CDC released hospital sepsis program core elements to outline structural and procedural components that are associated with multidisciplinary expertise required to support the care of patients with sepsis. The core elements emphasize integrating sepsis activities into antibiotic stewardship activities and engagement of antibiotic stewards in the development of sepsis treatment recommendations. And then lastly, just wanted to briefly highlight education and communication. We have many resources for healthcare professionals as part of the Be Antibiotics Aware campaign. Here's an example of what we are calling antibiotic stewardship bundles that were posted last fall. We often receive feedback that it would be nice to have bundles to really incorporate similar themes within one kind of clicking. So here's an example of our resources for the transition of care bundle. This shows our fact sheet for stewardship consideration at hospital discharge, including a social media graphic, and then resources for optimizing the treatment duration. And then the bundle also links to a CDC funded resources developed by Henry Ford Healthcare System to implement stewardship at hospital discharge. And then here is another example of a dental care bundle and the resources that we link to. And then I think I've been presenting our stewardship training for probably since 2017. But I just also wanted to highlight that we continue to update our training on antibiotic stewardship. It is mostly focused on outpatient prescribing for frontline providers, but however, many of the modules can be used for healthcare professionals in other settings. We have a nursing home module, we have a hospital module. The three first modules are an overview of antibiotic use and resistance and the core elements, and it does provide at least 8 hours of complementary CE for multidisciplinary physicians and pharmacists and nurses, and the course is available at this link. And then through cooperative agreements, also wanted to highlight that we fund online education with OSAP, which is the organization focused on Dental Infection Prevention and Safety Association. And then also through the end of the year, a cooperative agreement with SHEA. We have a course on advancing health equity through antimicrobial stewardship that is available online, although the CE is only for physicians. But we are working with SHEA this upcoming year to post, hopefully later this year, a course that will include 3 modules on penicillin allergy and delabeling. At this time, really want to thank everyone's attention, and we'll answer questions after our next presenter during the panel discussion. Thank you.
Thank you, Melinda. That was very, very good knowledge for us. So I know we're running maybe 20 minutes behind, some of it because we had such a good gathering, and it took a little longer for registration. So hopefully we'll make it up with lunchtime, and afternoon sessions can stay on track. Without further ado, going to invite Christina Cordero from Joint Commission up here. Just a few words. She's going to get us the regulatory update, our favorite topic. And who better than Joint Commission? Dr. Cordero is a Senior Project Director, Healthcare Standards and Development at Division of Healthcare Quality, Evaluation and Improvement at the Joint Commission. Dr. Cordero leads standards development projects for the new accreditation and certification requirements and survey process across multiple settings and programs. She serves as a subject matter expert for several topics, including healthcare quality, equity, antibiotics, stewardship, telehealth, etc. Prior to her joining the Joint Commission, she conducted basic science and public health research at Northwestern University's Feinberg School of Medicine. Dr. Cordero earned her doctorate in immunology and microbial pathogenesis and her master's of public health degree from Northwestern University. Please, everyone, welcome Dr. Christina Cordero.
Hey, thank you, everybody. And yeah, it was between my husband and I, we've been to most of the schools in the state of Illinois. He went to Benedictine down the street. We met at Northwestern. I did my bachelor's at University of Illinois down in Champaign. He did a postdoc at University of Chicago. So we have a lot of sweatshirts at our house, and they're all from Chicago-based related schools. We're both Chicago kids, actually, when we got married, as an aside, totally unrelated to my presentation, but just Chicago-centric. We had deep dish pizza at our rehearsal dinner, and we stopped for hot dogs on the way between our church ceremony and our reception. So we are Chicago through and through at our house. And everybody always asks me if I actually ate a hot dog in my wedding dress, and of course I did. And I had a milkshake because I hadn't eaten for 3 weeks before the wedding. So, but yeah, so today I know we are running a little bit off time, and I don't want to stand in the way of a coffee break. And I'm secretly hoping there's those DoubleTree cookies maybe at the break as well. But I just wanted to spend a little bit of time here just talking about the Joint Commission's antibiotic stewardship initiatives over the years. We have standards across multiple programs. So I just wanted to give a brief overview, focusing more on the hospital standards, just because we updated those about a year ago, but I did want to also highlight a couple of resources that we have for our other programs as well. I'm also 5 feet tall, and I wore flat shoes today, so I know you're seeing ahead, so I'm going to try to move slightly to the side. Okay, so I don't have to tell this group how important antibiotic stewardship is. We know that the inappropriate use of antibiotics contributes to antibiotic resistance and adverse drug events. And the way we've tried to address that at the Joint Commission is really by making optimizing the use of antibiotics a patient safety priority in the organizations that we accredit. So that's how we've tried to focus our efforts on evaluating the antibiotic stewardship programs within our accredited organizations, because they really do play a critical role in promoting appropriate prescribing practices and reducing that antibiotic resistance. I know this is a super tiny slide, but you all will have copies of these on the flash drives. This is just to show that the Joint Commission has been working in antibiotic stewardship for quite some time. So this is just a short timeline. We started looking at standards for the hospital program and our nursing care center programs back in 2015, and we released those standards in 2017. In 2018, we brought together a large group of experts in antibiotic stewardship over to the Joint Commission and had this sort of large one-day meeting on looking at leading practices in stewardship across the hospital and the outpatient setting. So we brought together folks from the CDC, Pew Charitable Trusts, as well as other leading people in the field to just talk about what organizations were doing and what was really feasible for us as we thought about updating our standards. And so we really wanted to know, before we put new standards out in those manuals, can people actually do these things, or what resources would organizations need before we went through with implementation. In 2019, we did a research study out of our Department of Research looking at the prevalence of those leading practices. So really starting to do some interviews with organizations to see if organizations across the country could implement these practices, what those resources were, and so that if we incorporated those practices into our standards, that we could help organizations with that implementation before our surveyors arrived on site. In 2020, we released a separate set of standards for antimicrobial stewardship for the ambulatory program. And that's because we know we didn't want to have the same standards for the hospital setting as for ambulatory, because there's just different challenges in that environment. So we worked with a different set of experts to develop those standards. And then the CMS released their new conditions of participation for hospitals. The CDC had updated their core elements. And so in the last couple of years, we started a new project to update our hospital requirements. And so that's what I'll spend most of the time today talking about. So this is just an overview of those standards in the hospital program. The goal was to develop new requirements to address new challenges in stewardship, as well as to revise and streamline some of the language that we had in those existing standards, just to better align with the other guidance documents that were coming out at the time. So the standard, everyone's favorite standard in the hospital program, is Medication Management Standard 911. It has 12 elements of performance within that standard. So those are the scoreable elements that our surveyors ask about on site. And we released that updated requirements in January of 2023. I know this audience has a number of different folks coming from different settings. So just to highlight again, in nursing care centers, we've had standards in our manuals since 2017, and that's the same number at MM 090101. And then in the ambulatory program, we released a standard in 2020. So we'll talk about that as well. So just to give an overview, this is the actual language of the standard itself. Hospital establishes antibiotic stewardship as an organizational priority through support of its antibiotic stewardship program. So again, really trying to drive home that message that it needs to be an organizational priority that also includes designating a leader, having resources that are focused on antibiotic stewardship to help promote and support those programs. I mentioned there's three kind of main foci of the standard. One was to incorporate new components that we wanted to include in the standard. The second one was to align with the CMS conditions of participation, because we're always looking to make sure that we're mirroring that condition of participation language, and we're applying those requirements to all of our accredited hospitals. And then we did a number of editorial revisions, as I mentioned earlier, just to streamline the content and kind of in the hospital program, we did shift the terminology from antimicrobial stewardship to antibiotic stewardship, because we were trying to better align with the CDC and the CMS core conditions of participation. One of the other things in the hospital program is we renumbered those requirements too. So if you've seen those standards and you've worked with them in the past, we moved them, shifted the numbering, and that's just sort of a structural artifact because of the way that we have our manuals organized. So I just wanted to pull a couple of the components of this standard, just to highlight a few of them. Again, in the slide sets, and we have a number of resources that provide the full context of all of these standards, but just a couple of highlights for the group. One of them is we have a requirement to allocate financial resources for staffing and information technology to support the antibiotic stewardship program. So again, the idea and the intent behind this requirement is for a hospital to demonstrate their commitment to antibiotic stewardship as a patient safety priority, and to make sure that staff have the time and the expertise to implement successful activities. We're not prescriptive about how many staff, how much time, all of those details, just because that can vary based on the size of the organization, complexity, and the scope of the services that you provide. But we did want to get something into the manual that really delineates that you need to dedicate financial resources to stewardship, and also acknowledges the need for IT support. And just because we heard that loud and clear when we spoke with our expert panel during development, it was really important to be able to identify that in the standards, and then for our surveyors to ask about that directly when they're in your organizations on survey. We talked a little bit about this earlier. I think that one of our other standards is to identify a leader. So making sure that the governing body in the hospital appoints a physician and or a pharmacist who's qualified through education, training, or experience in infectious diseases and or antibiotic stewardship as the leader of the antibiotic stewardship program. So it can be a physician and or a pharmacist. They can lead the program, co-lead the program. It can involve, it doesn't necessarily just have to be one person, but we just wanted to make sure that there was this accountability for the program's activities and outcomes. And the appointment of that leader or leaders is based on the recommendations of the medical staff and pharmacy leadership. One thing to point out here as well is just that for organizations that are part of larger health systems, sometimes we get that question, does it have to be antibiotic stewardship leaders at each organization, at each site, or can it be at the system level? And it really, it depends on how you want to structure your program, but some organizations do appoint a leader at the overall system level, and then at the individual sites, they still have a point person or a champion for the implementation of those different initiatives, just because there may be nuances with the patient population or the different challenges that they may be experiencing. But some organizations do appoint one leader over the entire system and then again work with the individual sites as necessary. Leadership responsibilities, I won't read all of this. It's very similar to what's in the CMS condition of participation, but this is just an overview that we want to make sure that the leaders have a hospital-wide antibiotic stewardship program, that they're documenting activities and antibiotic use issues, documenting improvements over time, and that there's this process to collaborate across the organization. And I think that's one of the things that our surveyors will ask about during a survey is who's involved in that collaboration, how are you working with the organization, across the organization, to implement stewardship activities. And then this last point towards the bottom is just about making sure that there is responsibility for that competency-based training and education. Multidisciplinary committee, I think Melinda talked about this earlier. The hospital has a multidisciplinary committee that oversees the program. This is a long-standing requirement that we've had in our manuals for years. Again, recognizing that antibiotic stewardship is not one person show, and there's really a lot of people from a lot of different aspects of the organization that should be involved. And so we do allow some flexibility in terms of the composition of that program and that team. Again, our surveyors will want to know, who's on the multidisciplinary team. How did you decide, who should be involved and which departments should be represented? How do they interact with each other? How frequently do they meet? And so that kind of discussion is what our surveyors will be interested in, but there's a lot of flexibility for your organizations to figure out how you want to form that team and run that team. It can also include part-time consultant staff. There were some questions about telehealth involvement as well for those of you who have kind of those relationships in place. So again, that's all well within the realm of this standard. It's just about making sure that you can articulate that to the surveyors and explain who's on the committee and how it works. Documented recommendations. This is another requirement that tracks very closely with the Centers of Medicaid and Medicaid Services condition of participation here. The antibiotic stewardship program documents the evidence-based use of antibiotics in all departments and services of the hospital. This is not to say that you have to document every time an antibiotic is used. I think that was the #1 question that came out when we released these standards. Everybody was like, do we have to do this every single time? And it's really about making sure that your organization's antibiotic use is consistent with the documented program recommendations. And so that you have a document that shows what those recommendations are and that that's implemented in the different areas of the program. Monitoring antibiotic use. Again, this came up a little bit in what some of the earlier presentations. We do have flexibility here for how organizations want to do this in the hospital. You can monitor antibiotic use by analyzing data on days of therapy per 1,000 days present or 1,000 patient days, or by reporting antibiotic use data to NHSN into the antibiotic use option of the antimicrobial use and resistance module. So some organizations are doing it one way, some are doing it the other. You don't have to do it both ways, although many organizations are now reporting to NHSN anyway. So I think we encourage organizations to do that. And when we put this standard in place, that is the direction we were hoping folks would go. So we are encouraging organizations to electronically submit that information, but you could also report it by doing these calculations. Strategies to optimize prescribing. This requirement and the one and the next slide. Again, there's some opportunity for organizations to implement this depending on the services they provide in their populations, but we're looking for the program to implement one or both of these strategies to optimize antibiotic prescribing, either pre-authorization for specific antibiotics or prospective review and feedback. And so again, there's a number of resources we have on how organizations do that, but we do have flexibility built in here in terms of how these strategies are implemented based on your program's expertise and complexity. So again, that's a discussion with your surveyors about which one did you implement, why, and how you're doing that. Implement guidelines. I know this is very difficult to read, but this is just to state that we do have a requirement that antibiotic stewardship programs implement at least 2 evidence-based guidelines to improve antibiotic use for their most common indications. So this is just a list of examples, but again, it depends on the priority areas for your organization and the complexity that you're seeing. So there's some flexibility here to tailor this to fit what your priority areas are. And then evaluate adherence. So you've implemented those evidence-based guidelines. We also want to make sure that you're also able to track adherence, including antibiotic selection and duration of therapy where applicable, to at least one of those guidelines. So we hope you're tracking adherence to both, but our surveyors will definitely want to ask about what your adherence is to at least one of the guidelines that you're implementing. How is it working? What changes do you need to make? You can measure adherence at the group level, so department, unit, clinician, subgroup level, or at the individual prescriber level. Again, it depends on how your system is set up, and that will just be a discussion about how you're doing this and why you're doing it the way that you're doing that, and is it working? You can obtain adherence data from a sample of patients from relevant clinical areas, depending on that priority area, or by conducting chart review. So again, a lot of flexibility built in here. We have expectations for what we want to see in an antimicrobial stewardship program, but how you implement that is really dependent on your program and your organization or your system. And then that's just a discussion you'll have with the surveyors about how that's working. And then once you've done all that, we also want to make sure your program is collecting, analyzing, and reporting data to hospital leaders and prescribers. So again, a lot of open flexibility here in terms of how you disseminate that information and what types of information you're providing to leaders. We just want to make sure that there is some information being distributed about how your antibiotic stewardship efforts are going. And if there's also a need for additional resources. So you want to share the successes, but if there's a need to change something or need additional resources in a certain area to help improve with implementation, that's also an opportunity to share that information with your leaders and prescribers. In terms of resources, I realized I just was in a meeting this week. We have a portal on the Joint Commission website that has some of the resources that we've put together over the years on antibiotic stewardship. I was just in a meeting looking at the prototype of the new portal, which will have a completely new address and link, which is not the one that is on the screen because it has not launched yet. So for now, this is where our antibiotic stewardship resources are located. When we launch that site, I can get back in touch with the team here and see if we can disseminate that link out to everyone, just so you have the updated version. But just so you know, we have a little bit of the background on the standards up on this website. We put together what we call the R3 reports, which is kind of an overview of the requirements, the rationale, and some of the references that we used in development. So we have resources and that type of document for the ambulatory standards, the nursing care center standards, and these hospital standards that I just talked about. So if you're interested in kind of a little bit of the background on those requirements. And then in this lower corner, we also did an on-demand webinar outlining the hospital standards and providing a bit more of a deep dive. I gave you some highlights of those standards, but that webinar really goes into detail in terms of what was the background behind the standards, what are we really looking for, what are some tips with as you go through your survey, what kinds of things should you be prepared for. So right now that link is on this website, and when this website shifts, we'll make sure that that link is still available, because I think it's always nice to kind of hear a longer presentation just to get some of the questions answered that you might have. I will say, full disclosure, it is also just me talking, this time for an hour on that webinar, but it does provide a walkthrough of those standards. And then just to highlight here, we do have standards, as I mentioned, in our nursing care centers program. It's still at the same number of the standard as our hospital program, but the requirements are different elements of performance 1 through 8. The requirements here are focused on staff and resident education around stewardship. There's that same expectation for the multidisciplinary team. That expectation we have across all of our settings. And then it tracks very closely to the CDC core elements for nursing care centers. As I mentioned, we have that R3 report that provides some background, as well as some standards frequently asked questions documents. I think as we have these conversations with organizations, with our surveyors that are out there on site, we get a number of questions over the time. So we always try to write some FAQs just to kind of provide some information upfront so that you can have some additional resources as you look at implementation. And then for ambulatory care, I mentioned those requirements we released back in 2020. We actually started the ambulatory standards project back when we did nursing care centers and hospitals. But at the time, the requirements that we had, that we were proposing, just didn't make sense for the ambulatory setting. And so we went back, brought together another panel. The CDC core elements had just come out for outpatient. And so we really tried to refine those requirements at that time. And so that's why the standards were released at a later date. That standard is slightly different in numbers, so it's up here. The standards on the ambulatory side are much more flexible, I would say, than on the hospital side, just because, again, priority levels are different in that area. So a lot of the standards in our ambulatory program are about the organization identifying a goal for stewardship and then aligning all of their activities for education and training to that goal. And we're not prescriptive about what the goal should be. It's, again, up to the organization and what their priority areas are, what their patient population is. And then we just want to make sure everything is leading towards that goal and that you're able to adjust your plans accordingly or provide updates on your success. I will say also on the ambulatory side, our ambulatory program encompasses a lot of different types of organizations. So we also have a lot of folks that will say, does this standard apply to us? We don't prescribe antibiotics. And so the idea is that that standard applies to organizations in the ambulatory program that routinely prescribe antimicrobial medications. So medical and dental offices, episodic care, urgent care, occupational worksite health, and convenient care are the groups that we identified. So ambulatory surgery centers are not part of that. So that's probably another big question that we receive quite a bit. And with that, and that was my last slide here. This is a link. I know it's difficult to see, but this will go directly to our standards interpretation group. If you have questions about the standards, you can submit them to that online form, and then it will go to one of my colleagues in that group to answer about the standards. So with that, I think we're doing some group Q&A here. So I thank you very much, and I will turn it back over.
Thank you, Christina. I know I've been sitting here. So it's a stewardship conference, not a HEMON conference. So we're not talking about DVTs. So yeah, we'll get, while we get the speakers up here, and the experts, if people want to just stand up for a little bit and stretch their legs, we will get our break on time, pretty much on time. I know we're running late. All the experts are here. You will find them in the poster rooms during the lunch. If you have questions that we are not able to cover during the allotted Q&A session, please feel free. We want all the questions answered. So we have two mics here. Sylvia and Gio from Simpar have graciously agreed to run around. And so again, thank your speakers for doing this for us. Melinda, are you still here?
Yes, I am.
Okay, Melinda is here, so that's all matters. Okay, all right, question number one. For our experts here, I know we covered a lot, and I know we have a lot of long-term care, a lot of acute care, ambulatory setting, dental settings, all different disciplines are here. So any questions for experts? And if you just introduce yourself real quick before you ask your questions.
Can you hear me?
Yes.
Good morning, everyone. My name is Mirza Ali, and I am from St. Anthony Hospital in Chicago. So far, I've enjoyed the conference, all the presenters, key contents, it's a jam-packed agenda. I'm enjoying every bit of it. My question is, some of you may have already talked about it. So antibiotic stewardship, what about antivirals and antifungals? Is there any discussion or research on that?
I mean, I'll say overall, our goal is for antimicrobial stewardship, which encompasses antibiotics, antivirals, and antifungals. So a lot of our efforts are focused in all three settings. I know the language differs across, especially we were talking about earlier, antibiotic versus antimicrobial. I believe the reason, and Melinda, if you want to hop in, I remember you speaking about this once, but I believe the reason CDC doesn't use antimicrobial is because of the general public relating more towards antibiotic and antiviral, and not necessarily the term antimicrobial. But Melinda, if you want to add any more to that, I will say overall, all of our goals at the state level, we focus across the board in terms of all antimicrobials for all healthcare settings.
Yeah, thank you. And then if Joint Commission wants to weigh in, I'll give your standards on that.
Yeah, so I was gonna say the same thing. We wouldn't exclude those things. I think that in our, right now with the language change, we just changed it for hospital, again, just to maintain that consistency with the CMS conditions of participation, but our other two programs still say antimicrobial. But again, it doesn't mean that in the hospital program, we wouldn't want to ask about that or wouldn't want to know about that. It's just because it was tying so close in the language for CMS that we shifted it. But I think we're still interested in organizations looking across the board at antimicrobial stewardship.
Melinda, Melinda,
Yeah, oh, yes. This is a great question, and agree that most hospitals and health departments focus on antimicrobial stewardship. I think it's more of a nuance at the CDC that we use antibiotic because we do a lot of public messaging, and our communication team felt that we needed to maintain the wording of antibiotics for the general public. But we do focus, at least at the CDC, on antimicrobial stewardship. Our team mostly focuses on antibiotics, but we do have a mycotics group that is doing a lot of work on antifungal stewardship, and we collaborate with them as well.
thank you. And that's several times during, as I've been here 10 years, doing it every year. Starting antimicrobial stewardship nationwide, fashionable thing is antibiotic stewardship. But we here as a team, for 4 or 5 years, have steadfast used the term antimicrobial stewardship. And so good points there. There's a lot of discussion that happens on the mycotic side. And I definitely have a lot of academic researchers in the room that have done a lot of work. So please, although you're here in the audience, if you have any comments to add from your subject matter experts, please raise your hand. And if you have something to add, do that. So, and again, thank you. Does that answer your question? Good. Thank you.
Just to add on to that regarding the CERN projects, I'm Mike Closer, and I'll be here talking to people about CERN. CERN does track antimicrobials, antifungals, antivirals in the database. So for the tracking and reporting, anti-corrosive use will include that as also we include some tracking of diagnostic stewardships as well. Is Jamie mentioned, especially for acute meningitis, we're looking at use of tests. So we utilize the broad definition, as well to help track all those issues. Thank you.
Good morning. My name is Naya Hopkins. I'm the infection preventionist for Pavilion of Bridgeview long-term care facility. And I just want some advice on how to get nurse practitioners and the MDs compliant when it comes to antimicrobial stewardship, because like a lot of them like to do non-evidence-based testing of urine, like when a patient has a bone and things like that. And I get a lot of pushback on the testing with no symptoms or anything like that. And of course, they always come back with something, but there are no symptoms. And another question is, should our policies at a nursing home mimic those IDPH needs?
That's a great question. So I think Jamie, you want to start?
Yeah, I was gonna say, Rob, you wanted to mention our recent discussion about engaging prescribers.
Right, we will, with, I'm the moderator. And I mean, there was a comment, I think 2 years ago, the moderator set up their experts. I took that to my heart, so.
Eric mentioned that because we've been working directly with some Health Collaborative, as well as a number of our, stewardship efforts in the long-term care setting. But I think engaging those providers in conversations, engaging our facility leadership, we are working to develop prescriber feedback reports that monitor their prescribing and provide some feedback as to how they can improve their antibiotic prescribing practices. I think there's often a lot of politics involved in the long-term care setting in terms of engaging with frontline prescribers or the veterans as well as with the frontline prescribers. So I think there does need to be a bigger conversation with facility leadership, with the medical directors to engage with those prescribers directly and just provide them with some feedback. And that's anything else that you wanted to.
I was just gonna say that's one of the reasons I think we have that multidisciplinary team across all of our, that expectation across all of our programs is really just to keep trying to get everyone at the table early on so that you do have some of those champions that then when you do your implementation, they can kind of help with some of those discussions as well. But yeah, we hear that as a challenge as well. When we put these standards out there, how are we gonna get everyone to do this? And I think that's one of the components of that multidisciplinary team that I think might help.
Melinda, you have a quick comment and then I will make a few comments.
Yeah, just to clarify, was the question nurses, educating nurses in nursing home or across all settings?
Nurse practitioners, and I guess what I'm trying to say is like, I have a lot of nurse practitioners that come in and they test urine for no apparent reason at all.
So I can rephrase your question, so it's more clear on remote attendees. So the question, Melinda, is how do you ensure the practitioners are using evidence-based diagnostics and then prescribing for infections? And very commonly in long-term care setting, and let you know if I'm paraphrasing correctly, there are testing being done for not appropriate guidance-based reasons, and then the results also get treated with antibiotics. So the question is, how do you have how do you ensure the practitioners are using evidence-based medicines, or at least in long-term care, the guidelines that are being established? So anything from CDC's standpoint?
Yeah, that's a great question. And I mean, I think more broadly, we are really focused on ensuring education to APPs. And I think I showed that slide that they account for about 1/3 of antibiotic prescribing now. And so we are, one of our colleagues on our team, Memo, he's a physician associate. And so he's been really working with professional societies and incorporating educational sessions within the NP and PA like annual meetings and local chapters and whatnot. And so we are trying to focus on education within those specialties on antibiotic stewardship, and specifically focusing on common infections like CAP and UTI and upper respiratory tract infections. And then we are trying to create more resources for the nursing homes. We've heard from our state health departments and large local health departments that enhanced resources for nursing homes would be beneficial. We do have some already about optimal communication with family members as well as the patient or the residents in terms of the UTI, and not treating, not testing or treating asymptomatic bacteria. So that might be a great resource that you can think about incorporating at, for NPs and other practitioners at the long-term nursing.
Thank you. And then just from the work we have done under the partnership with IDPH, we are in year 3, and every year, at least in the first year, there was a full session which is available recorded with the CEUs that talks about how you prepare your prescribers report and present the comparative peer analysis to the prescribers, and also how to have that difficult conversation when you are doing your antibiotic analysis and you do think there is a fallout where someone is not following the guidelines, and in our session we talk through what is the best way to get this news. It is difficult when to tell somebody that that you're not doing the right thing, and we know there's an art and also science of first of all doing that review, and then once you do that review, get that feedback. So also that's been done in the past and is reported, but we also both online and in person. I think Jim showed that schedule. One of those sessions will include how to get the prescribing reports and relate it. And I think the key there is, though, your medical director has to be involved in that process. And if you have difficulties, again, we'll be here all day. Our information is available. We can help you through that process, because that could be hard. But that needle gets moved only once your medical director is involved. So.
Just to add to that, I think it is helpful to have standard language in place, common scenarios like asymptomatic bacteria and appropriate testing, to have standard language in place so that when you do speak to a similar provider over and over, if they are hearing the same language from all those nurses, I think it might hit a little differently after a certain number of times. So working with your stewardship to have a protocol in place for scenarios such as asymptomatic bacteria, and then standard language that each nurse can utilize when speaking with the provider about that particular scenario.
Hi, my name is Tanya. I am also an infection prevention nurse. Today is my 1-year anniversary of being in this great profession. I've been 17 years at the nursing home I work at, so 14 years nurse. But anyways, I work at long-term care. I work at a small nursing home in Elgin. We are not part of like a large network. So I just had the medical director and one other doctor that I typically coordinate with, but I wanted to speak to her issue, which is, what do you do when a doctor's prescribing a UA or an antibiotic and you're like, hold on a second. Thankfully, Dr. Mueller knows me very, very well because she's been our medical director for a while. So when she sees me coming, she's like, what did I do now? But what I've done, I've had, I'm sure people know that or they've had like nurse practitioners who are like psych NPs, and you've got a resident who are having behaviors or agitation, and they're like, check their urine. It's like, but there's nothing else going on. So why are we doing that? So what I did in that instance is I actually emailed that provider and said, hey, listen, here's some data based on like what we ought to be doing, and we really should not be testing urine for just agitation. Like, what are their other symptoms? So can you include, if you feel like the UA is appropriate, can you include like some language to give me some wiggle room to do like an infection watch for 24 hours and see, are there any actual symptoms? Are they having dysuria? Are they having more incontinence, et cetera, et cetera. So I've got a little bit of wiggle room, but also I've had issues. I love our medical director. She's amazing, but I presented her with some information of when I'm putting in my tracking, and I've got, the Minnesota Department of Public Health has their tools, and they've got a really good antibiotic tracking tool that I've been using, and it's got all the nice printouts, so I can show like you know, here are the percentage of prescriptions that are meeting criteria versus not. And I think a lot of, oh, that's just a continual conversation of like, okay, we're gonna put somebody on, but how fast can we get them off if there really isn't meeting, you know? And I think that's just a continual education, even if you've got the rapport with a doctor or a nurse practitioner. There's so many, and they're actually, you know, they're good at their job, but it's like, there's so much ingrained, I mean, again, this is not taught to nurses in nursing school. Like, I did the CDC training, I was like, oh my goodness, I've never questioned antibiotic in my life, and now I question everything. So, I think, just want to encourage you, like, you're.
I work with a lot of business practitioners, so you try to suggest things to them and you can have, they kind of try to know it all.
Thank you. So just, we'll try to get one more question in. This always, okay. And if we, maybe two of you talk really fast, but no. We have some really, you know, swashbuckling nursing facilities in the room that have taken on our first cohort of Palace and done some real changes. We'll see their results. So it's been done. So the concurrent nursing home sessions, the long-term care sessions, you meet them. And this is the thing, we'll have a community where we learn from each other. So, so please, this discussion is not over. We can be here till next week and still talk, right? So let's just get some time, but at least get together. I know you'll all be in the long-term care small group. Learn from we have Willis Calabrini, we have Sunny Hill, we have Pavilion. We have so many homes that are done good work. We'll all come together and discuss. Go ahead.
Hey, good morning. This is Simon. I'm from Television, your quality improvement organization in the area. I would like to comment from you about the determinant of health. How do you think the determinants of health are impacting the microbial utilization?
So, I think, and are you asking that in a particular setting, acute care, long-term care, outpatient dentistry, or it's just a broad?
I know the CDC is going to be requiring certain determinants of health to be reformed. So I was wondering if you guys have.
Melinda, would you like to comment on that?
Well, Melinda, if you don't have a chance to hop in, I'll just say that's a really wonderful segue into our next topic, which will be covering that in depth. So if you don't mind just holding off that question until that presentation, or if you have questions following that presentation, I think we might get a little bit more insight.
All right, next person.
Yeah, hello, Eve Hills, Lake County Health Department. Just as a follow-up to the ladies from the long-term care facilities, I wanted to get the panel's opinion on where they see the strongest interface between a provider / prescriber and, you know, subject matter experts, the people pushing for better antibiotic or antimicrobial stewardship practices, where that interface is going to be the strongest within their own facilities, with state health departments, with educational institutions. Want to do the panel's view on that?
I think, Jamie, you can probably comment on that. I think the question, I think we answered your question, and that is the medical director is the interface. So the question is, where is the medical director, right? You know, I mean, how many medical directors in the room of a nursing facility, right? So, we made it here, and I think it's a 300% growth. Right? So for 9 years, it was like one person, and if anybody else. So thank you very much for coming, and that speaks, and that's still growth. You know, health departments, local, state, are there doing their best. CDC has a lot of information through AHRQ, and again, if you are joint commission, the predator, there's so much
work around medical records role, not just in stewardship or in passenger care, but also on opiates, all other topics. There's so much, there's so much, focus on having the medical director be in that, clinical leadership position, and that is the liaison between the bedside care and the facility. So I will continue, and we were, as we were planning this summit, for several weeks, trying to see how many, medical directors we can get in the room, because this question, believe it or not, every year the same question comes up. How do we get, the nurses are empowered now, they're doing their competency, they're taking you are all here, pharmacists are all, up to speed with best practices, but we definitely have to get the practitioners also get to know, because a lot of their training, as you said, nurses will learn that in nursing school. Same thing, a lot of the nurse practitioners and the doctors, and I give my example, when I trained, I did not go to a nursing home for even one day, right? So that's why a lot of people become hospitals, and there's the nuances between practice and hospital, practice and nursing home. And so as hospitalists, both doctors and advanced practitioners go into nursing homes for security, they got to learn that, and we have resources. IDPH has been, generous enough to sponsor a lot of that. So just, thank you, and local health departments that are very, very pioneers and facilities, you are making a difference. I think we're going to see changes in Illinois as a state, and so I know we're almost at time. Is a fast speaker with a fast question that we can quickly answer?
I also just wanted to add to that long-term care question. The great thing about long-term care and hospital as well is that many of the resources are already widely available in terms of like the standard language to use, different protocols. I very commonly go to the Nebraska ASAP website. Minnesota Health Department has numerous resources. So you don't have to reinvent the wheel or start from scratch ever. You can likely find something that someone has already put in place on one of those different websites.
Do we have a quick comment from the medical director in the room? So we can actually mention Taiwan. Break is canceled.
Medical director at Department of Human Services in Boston, so to help you right here is like, where your medical director facility is like a coach to your sports team. So if you see, you cannot see what the players are doing, but your medical director can. If you see there are things between three countries or not playing the game well, then your medical director is the one to ask you a question. Now, in terms of medical director, they're perfect, kind of mediator for you guys to understand why the antibiotic was used or not, and why this physician is prescribing more antibiotics than they want. There are all these dynamics involved in clinical practice. Roger, internal medicine, you know it very well. Like a person, if a physician is ordering UA, you must understand that there might be a reason other than just the clinical symptoms, possibly the visual that the physician is trying to treat is nonverbal, not able to